Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for episode 3 of the CMEOCast, Improving the Application of Shared Decision-Making in the Selection of SLE Treatments. This podcast series is supported by an unrestricted educational grant from AstraZeneca Pharmaceuticals. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine, an attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York. I'm joined today by my friend and colleague, Dr. Richard Fury. Dr. Fury is professor of medicine at the Zucker School of Medicine at Hofstra Northwell and chief of the Division of Rheumatology at Northwell Health in Great Neck, New York. Welcome, Rich.
Thank you, Alan.
In addition to CME and CE credit, today's activity is also eligible for ABIM maintenance of certification points. Once you complete your activity, provide your ABIM ID and birth date when completing the evaluation, and CME Outfitters will submit your maintenance of certification points. You can also claim this activity as a CME activity for MIPS improvement activity. Over the next 90 days, actively work to incorporate the improvements in your practice presented in today's activity. CMEO will send you a follow-up survey at the end of that time, and upon completion of that survey, CMEO will send your confirmation to submit to CMS, attesting to your completion of a CME for MIPS improvement activity. Activated and educated patients who are engaged in their care as stakeholders are much more likely to adhere to the agreed upon strategy and are much better advocates for their own care. Given that, our learning activities and our learning objectives for episode 3 is to incorporate shared decision-making into the selection of safe and effective SLE treatments so as to better improve disease outcome. Now, as we know, and as perhaps you've heard in one of the other podcasts of this series, lupus is a clinically heterogeneous disease with numerous manifestations, many of which are listed here. These are the more common ones, but by no means is this list exclusive. Of course, as rheumatologists, we tend to deal with musculoskeletal complaints and then the constitutional symptoms of fatigue, arthralgia, fever, but we're also forced to look at a variety of other clinical domains in patients with lupus, such as the skin, the lung, neuropsychiatric manifestations, the kidney, the GI tract, the heart and vasculature, the eyes, the endocrine system, and the hematologic system. There's an old maxim that the one who knows lupus is the one that knows medicine, in an attempt to really make it clear to us that the variety of clinical manifestations and presentation necessitate that we have a understanding of all the organ systems of the body that can be affected by patients with lupus.
So Alan, what about the patient perspective? So patient-reported outcomes are certainly part of clinical trials in all different areas. And actually, I think a lot of clinicians use them in rheumatoid arthritis and psoriatic arthritis. What about the application of patient-reported outcomes to lupus?
Good question, Rich. And while they are used largely in many of our other diseases, they're used largely in patients with lupus as well. Patient-reported outcomes give us insight into the patient experience of their illness, their values, their preferences, and their goals for care. And there may be, as we'll see, a dichotomy between what patients are looking for or experiencing and what we as physicians are focusing on. PROs, patient-reported outcomes, may be useful as predictors of increased risk of mortality in our patients with lupus. And because of the ease of their use, patient-reported outcomes can be measured easily, quickly, and reliably, especially in communities where access to rheumatologists may be limited. And indeed, in this current climate, where telehealth has become so important, patient-reported outcomes may help us assess disease activity in our patients in the absence of our ability to actually lay our hands on and do an assessment of the objective signs and symptoms that we're looking for in our patients. Even if it's not formalized, I think that it would serve us well to ask our patients about things like the importance of symptoms to them and how it is that they're doing in the context of their disease. We know, for example, that we have to also be aware of not using jargon in our patients with lupus. We know that we have to speak to patients in language that they will understand, which may be different from the language that we may be using with each other or with our staff in assessing patients in clinical trials. And understanding that the patient's health literacy may sometimes pose a barrier is very important in educating patients about the activity of their disease, about the therapies that we're going to be using, and about outcomes.
All right, Alan, our learning objective is about engaging patients in decisions about their care. I see a lot of lupus patients, and I'm not always sure they want to be engaged. What do you think?
Oh, Rich, there's really no question that patients do want to be engaged in their care. Whether it's by telehealth or an in-office treatment, today's patient and their families want more than ever in their treatment that they be engaged in their care. It's almost that they've borrowed a maxim from an old TV advertisement: an educated consumer is our best customer. And they really want to be involved in understanding what we're telling them so that they can be involved in making the decisions. They want to be included in the decisions that are being made about them. They want to be educated about their disease and treatment options, and they want regular updates on the progress of their care. They want to be treated with respect and dignity throughout the disease journey. And they really want to see options for treatment and arrive at the decision-making process in a shared manner. They see themselves as partners in their care, as well as primary directors of their care. Patients, more than we, Rich, have rejected the notion of physician paternalism and moved towards patient autonomy. And that kind of new approach is something that we as physicians are going to be encountering more and more in our patient population.
Yeah, but I must say, all too often, I get an answer. I'll give you the scenario. So I'll spend about 10 minutes discussing a complication of lupus or side effects of a drug. And I go through all of that. And then at the very end, they go, whatever you say, doc. And I find that so annoying. I said, well, we had to make a shared decision.
Well, it's more than annoying. It actually exposes us as practitioners to a certain degree of liability if we are making the decisions without the patient doing so. That gets to the whole issue of informed consent, which means that the patient is informed, but then they give consent. And the patient needs to be actively involved in making that decision. If we're making the decision for them, in the event that there is an adverse event, it can be problematic, partly in the legal arena, but even more so in the physician-patient relationship. So I would strongly advise that when you have patients, as I do as well, who say, whatever you say, doc, we really have to take the next step and prompt them by saying, no, it's whatever you say that we're going to be doing. Now, another problem we frequently encounter, however, is that there are significant issues or barriers to shared decision-making, not the least of which may be the patient's health literacy and the patient's ability to understand the terminology that we're using, which is a reason that we have to speak to patients in language that they and their caregivers will completely understand. Patients may be risk averse, and so we may want to do something knowing that the patient will benefit, but the patient may decline treatment or the treatment dose adjustment or the dose escalation because they fear worsening symptoms with changing therapies. They may want to be good enough even though we know that we can make them even better. Patients often give us choices or have their own choices about what the route of administration is going to be, oral versus infusible, injectable versus oral. And they're also concerned about the uncertain prognosis and self-limiting manifestations of lupus, and that's on their mind as well. And finally, we can't lose sight of the fact that there may also be financial or administrative burdens associated with the care of patients with lupus. But Rich, you encounter patients with lupus every day and maybe twice every 5 minutes. What are some of the treatment issues that you encounter? What's some of the pushback that you see from them?
Well, patients want to know about side effects of drugs, and you can't blame them for that. And I try to educate them about the more common side effects. A very common question is about future pregnancy. And an interesting question is, and it's fairly commonly asked, is about diet. You know, is there a diet that can bring down the activity of their lupus?
Yeah, I get that question as well. And I can't help but remember a maxim that one of my professors imparted to me, which was, when all else fails, find out what the patient likes to eat and forbid it. So I frequently employ that strategy. Sometimes it works, sometimes it doesn't.
All right, so let me ask you a question. So are there best practices or principles that we should adhere to in thinking about shared decision making?
Well, I think there are. I think both from the literature and our practical experience, we know that the best thing we can do is to create a supportive environment for our patients where they can feel comfortable talking to us about what's on their mind. We can clarify the timelines needed for them to make the decision and include in that discussion the opportunity to revisit the timeline at subsequent visits, and also to engage their family and caregivers as appropriate. What we do best is to identify the decision options that they have and the outcomes that affect those options, but then it becomes the patient's responsibility to make those decisions. We help the patient obtain evidence about the outcomes of the different options and then translate the evidence into an individual patient's situation. Issues related to concerns about pregnancy may or may not be relevant to certain patients. And so that becomes important for us to know in the context of shared decision making. Again, it's important to check the patient's understanding of what we're telling them for each option and outcome and provide the basic information that they're looking for. Many times the patient is sitting in front of us nodding, and what they're saying to us is, "I hear noises," which we interpret as, "I understand you completely." And that dichotomy is often vast. We should probably select the options and outcomes of most relevance to that specific patient. We know the menu, we can give them the menu, but we should focus on the options and outcomes that are most relevant to that patient if we can identify them. We should communicate the probabilities of the different outcomes for the different decision options. We should engage the patient in a discussion of their values, of their preferences, because engaging them and showing them that we're serious about understanding what's relevant to them is also important in influencing the decisions they make. And the decisions they make are going to be important in achieving the optimal outcomes in their care. We need to be supportive, offering advice as the patient requests it to inform their decision. And again, we need to be supportive of our patients in their selection of an option. So let me summarize our discussion with the SMART goals for this learning activity. We need to recognize the broad impact and burden of lupus on the quality of life of a patient. We need to integrate patient-reported outcomes measures and recognize that they provide valuable insight into patients' experiences of their illness, values, preferences, and goals of care. and we need to be able to implement best practices for shared decision-making so as to engage patients as partners in their care. If you've missed any of the other episodes in this series, I recommend that you check them out, whether you've watched this podcast sequentially or go back to the others. The learning that you'll get is both sequential and iterative, so you don't have to be concerned. And all 3 episodes, as well as a variety of other education and resources on inflammatory disorders, are available on the CME Outfitters Rheumatology Education Hub for both healthcare providers and practitioners. Again, a reminder to collect your credit for today's activity. Please click on the link, complete the evaluation, and you'll then be able to print your certificate from the platform. And as a reminder, if you'd like to apply for ABIM Maintenance of Certification credit, provide your ABIM ID and birth date when completing the evaluation so CME Outfitters can submit your Maintenance of Certification points to the ABIM. Thank you for joining us today.